going to do concussion, and then it's like, yeah, everybody's like, oh, 80 slides. I'm like, this one's like 30 something. I may, just so you know, I may keep pushing a little bit, and we might do like a little bit of a headache lecture too, so don't freak out on me. I'm just trying to make this the most efficient for you guys. I still have 2 more lectures next week, and I gotta hit. I want to do stroke like Tuesday morning when you guys are fresh, because I think that's a good one. Not that these are bad ones. And then we got to still do a review as well. So we got time. We got time. Y'all would smoke. Friday afternoon, I come in here. The first thing you guys are asking is, when can we get out of here? When can we go? This is miserable. And I'm like, all right, I hear you loud and clear. So we'll talk concussions. This is going to be important. So what do you guys think of the video? Video about Tua. Let's talk about that one first. So that was his fault? Damn, it was my fault. Yeah. All right.
He chose that career.
He chose that career, sure.
Well, the best part is that after the fact, like, hey, she went on. Nope.
Yeah, that's true as well. So they said he could wear extra protection on his helmet. He said no. That fencing, right, or that posturing, it's usually indicative of like deeper brain trauma to the corticospinal tract. So that's definitely a concern. You guys think you're going to see concussions? Remember I told you like yesterday and the day before, and probably the day before that, we talked about like Alzheimer's disease and Parkinson's disease, and I'm like, hey, got to teach you, it's on the pan, 7%, right? You might get a question. You guys are going to see this. I don't want to say every day, but you're going to see it. Like, what type of patients are going to come in with concussions for you guys? Athletes, combatives, basketball. Like, everybody wants to do fun stuff in PT. It's like, whatever, mechanics, ultimate frisbee, football, whatever, right? So you guys are going to see this. Just soldiering, obstacle courses, walking and chewing gum, like all that. I don't want to punk anybody out, and I can speak from my experience. I've had multiple concussions, in case you guys couldn't tell. Anybody else have a concussion in here? Yeah, they're pretty darn common. So that's the only reason I'm not going to ask you your personal story. But there's some like dark web video of my UMass concussion where I got knocked out and went to the wrong sidelines and got punked out. It's pretty funny. But hopefully it's gone now. But if I could bring it up, I would. All right, so we'll get into concussions. We'll talk about it. Video, I think, does a decent job explaining it, but I think it's kind of obvious, right? So, like, what, in your own words, what's happening with a concussion? Brain's bouncing around. What else? Just micro trauma to the brain, right? So, like, how do you explain? This is what I want you guys to start thinking about this. So, we'll ask some questions on the test about concussions, and I'll steer you where we're going to go, but how do you explain to your patient like what a concussion is, right? You say, oh, you know, you bonked your brain on the inside of your skull, and they're like, oh, what does that mean, right? It's just like a bruise, just like any other bruise. You know, you hit your arm and it bruises up. Well, the brain's the same way. So you got to kind of be able to explain that to them in layman's terms, and then also how do we treat? We're getting a little bit ahead of ourselves, but with a mild concussion, how do you treat that? Brain rest, and how do you get your patients to actually subscribe and adhere to brain rest?
Forcibly.
Yeah. What's that?
Forcibly.
You forcibly follow them home and tuck them into bed, right? No, you got to explain it, right? So brain rest to an 18-year-old first time away from home, they just think like, I'm on profile, I'm gonna go play Call of Duty for 24 hours. But no, dude, I need you to go sleep. Like that's when your brain repairs itself. So like, no reading, no Call of Duty, no phone. Nothing. Just go home and chill out. So sometimes they don't understand. All right. It's common. Kind of beat the dead horse. You guys can look at the prevalence, but it's going to be common in your population. So whether you're inside or on active duty or off. So my reserve and guard folks, you guys are going to see this too, right? We'll talk about distribution and who's going to come in, but I'll just give you the kind of the cliff notes here. So it's usually like younger folks, because they're daredevil, more active, and old folks because they're old and they fall. So I would like you to know the definition of a TBI, so please, I don't know how to get around this, but I do have a couple questions on there that are just definition questions. So alteration in brain function caused by external force and characterized by the following. You guys can read those. How it happens, head gets hit, right? Head hits something, A cell, D cell. So this is an interesting one. Like, if I was in a car going real fast and they slammed on the brakes, like you don't even need to hit anything. Just that coup-counter-coup force of the brain hitting the inside of the skull, right? It's just kind of buoyant in its happy place. If you stop fast enough, you can slam the skull or the brain on the inside of the skull. So patients sometimes might not understand that. You got to explain it to them. Forward body penetration should make sense, and then a force, like a barotrauma blast force, right? So, again, that's more kind of wheelhouse for us, right? Hopefully we're not keep piling up the conflicts, but if you see the last 20 years, I don't know, were IEDs effective against us? Fortunately, they were. So, blast injuries are something that probably our adversaries have taken note that those actually kind of work well. So hopefully we don't have any more conflicts, but if I was the enemy, I would be taking note. So, and then most commonly motor vehicle accidents, okay? And that happens all the time. If you don't believe me, just stand on the street corner in San Antonio and eventually it will happen, right? Anybody from anywhere that they think there's worse drivers than there in San Antonio? Where? Albuquerque, New Mexico?
Yeah.
I can't argue that. I've never been there. I'm from Boston. I think notoriously we have crappy drivers, like roundabouts, rotaries, like all sorts of things. People get out and fight each other all the time. It's like the drivers here suck. Like they're awful. That's just my opinion. It's worth this really quick. All right, classification, severity, GCS. I want you guys to know the GCS. I want you guys to know Glasgow Coma Scale. Have you been exposed to this previously? Okay, excellent. So this is all not new information, you guys. And if you don't know, right? So just remember from head to toe. Just remember 4, 5, 6, right? So your eyes, your mouth, your hands. So 4 points for your eyes, 5 for motor response, 5 for verbal response, 6 for motor. Excuse me. So it should just go sequentially from head to toe. And who gets a 0? If I'm dead and I'm on your table and you do a GCS, is my GCS 0? Nobody gets 0. So you can't get a 0 on this. Congratulations. So if I ask you a test question, your dead patient is there, you do a GCS, and I give you the choice of a 0, let's not argue about it later on. Let's give them a 3. They're not opening their eyes, they're not verbal, and they're no motor response. They dumb. They gone. But you can't give them a 0. It's like putting your name on your SAT, getting points. Focus 2, when you guys study, we'll hit in the review at the bottom there. So what delineates minor, moderate, and severe brain trauma? So minor, 13 to 15, excuse me. Moderate, 9 to 12, and these are points, right? And then severe is less than 8. You guys have probably heard the adage, less than 8 innovate. That largely depends, but that's usually pretty darn true. So. All right, decorticate, decervate posturing. You heard these terms before? Did you guys talk about them all? Okay, so you get hit hard enough in the head, or your patient is rapidly deteriorating. Kind of this nests nicely after stroke, but sometimes you'll see this in stroke patients. Decorticate posturing to the core, so they start posturing upwards, and then decervate posturing, they'll posture outwards, and it's progressively worsening symptoms. Okay. So decorticate posturing usually is flexion of the elbows and wrists with supination of the arms, and that usually indicates bilateral cerebral damage or damage to the midbrain, where decervate posturing is extension of the elbows and wrists with pronation, damage to the motor tracts, midbrain, and caudate diencephalon. So it's getting kind of deeper and deeper. So in general, when you see this, it says on my slides here, in general, decorticate posturing has a better prognosis, but both of these are not great, right? So our boy Tua in that first video, and he had another one. I chose that video because I think that was like his 3rd or 4th concussion, but one of the ones he had, which I couldn't find, he decorticate postures pretty good. It's a good example of it. And that just means that that's probably a moderate or severe concussion. So. All right, TBI types, mild, moderate, and severe. We just went over the GCS scores corresponding to each. And remember, so GCS is kind of internationally used. What do we use in the military typically for all my prior medics? Mace, mace 2, right? What's the problem? What's one of the issues with the mace exam? The time it takes to do it? Yeah, it's longer. Memorize it. Yeah, people memorize scores. So if I have to do a mace on one of my medics, you think they're going to do well on it? Yeah, they know all the answers. He's saying them up here, you guys can't hear it. So, right. So the mace is great. I think the mace. I encourage you guys to use it. I don't quiz you or test you on it. It's built into your electronic medical record. So like we'll use Genesis, which we don't show you guys at all. You can click on a mace and then just click the score. We use the GCS because it's down, dirty, quick and easy, and it's internationally accepted. Okay. So if you get time, when you guys get out of here today, hopefully soon, whenever we're done, you can look up MACE. You're like, yeah, we're not looking at MACE. Like, hell no. All right, mild concussion, we said 13 to 15 is their GCS score. That's the majority of them, so 90%, 79% of them. Minor head trauma, could get a brief loss of consciousness. They're awake in minutes, usually seconds, followed by symptoms. You could have headache, dizziness, nausea, single episode of vomiting, difficulty concentrating, brief amnestic period, and blurry vision. Typically they do well, and you guys already told me they do well with brain rest, plus or minus Tylenol, plus or minus Zofran if they're nauseous. But mostly brain rest, right? Do they need to get scanned? Tell me, you're in the ER, somebody comes in, it depends, right? So there's no right answer. There are some concerning findings, certainly. I would tell you that, like, most of the instructors hate when I say this, but nobody's ever gotten in trouble for doing too much in the ER. But if you miss a brain bleed, you're going to get sued and kill somebody, right? But that being said, if I have a patient that has, and I think a run-of-the-mill GCS 15 headache, maybe they got knocked out for a second, I can obs them. I can give them some treatment and see if they get better. I don't necessarily have to scan them right away. I might be a little bit, I might go a little bit slower on them as far as spinning their head. You don't necessarily have to. Some things I want you to consider. So again, clinical obs, discharge with observation as long as they don't go home. If they have somebody that they're living with, they don't live by themselves. However, if they have persistent severe headache, no improvement, you gave them a gram of Tylenol and they're like, I have a 10 out of 10 headache, right? You just had a concussion. I gave you a gram of Tylenol, I let you wait for an hour, I come back and you're like, now it's 11 out of 10. Like, well, that's concerning. But you know, I come back and you're like, yeah, actually it's like 4 out of 10, I feel good. That you have to use that kind of to judge or determine how you're going to treat this. If their headache is getting worse, it's persistent, repeat vomiting, 2 or more episodes, severe MOI, what could that look like? Car crashes, right? So you take a look at the car. My patients love to show me pictures of their trashed up cars, right? So always ask your patient, you know, were you wearing your seatbelt? Did the airbags deploy? Any prolonged extrication? Were you ambulatory at scene? Did you hit your head? Do you remember the event in its entirety? If they're like, no, actually I blacked out, I don't remember. Yeah, I got thrown from the car. No, they needed to use the jaws of life. You think I'm like, maybe we shouldn't CT them. No, I'm like, yeah, why don't you come to me? Like, we have a CT scanner open for you right now. We're going to get you over there pretty expeditiously. Those type of things. So consider the mechanism of injury. Baseball bat to the head, right? That's different from, I don't know, bonking your head against someone else's where you're catching a football or something. So underlying coagulopathy, if they're on blood thinners, congratulations, you're going to the scanner. If you're 65 and on blood thinners, congratulations. I don't even care anymore. I'm just like, we're going to scan your head. 30 minutes of retrograde or persistent amnesia, right? And then intoxicated. So circle the bottom one, circle that bottom one. Your patient comes in after an MVA, you diagnose them with a mild concussion, but they're drunk. Where do you think they're going? Why? Make that make sense to me. They're unreliable. They're drunk, they're unreliable, but they're like, I'm fine, doc, you know, I'm gonna go home. Those people are gonna go home and die. Right? They are unreliable. Like, you're like, wait, they were driving drunk? Yes, they always do that, right? But I don't really care about that in that time. I'm worried more so that I'm gonna miss a brain bleed. So send them to the scanner, please. Post-concussion syndrome. So your concussions, your mild concussion should be about 7 to 10 days and you should feel better. Okay? After that time period, if you're not and you're having persistent symptoms, we call it post-concussion syndrome. That's all I want you to take from this. So your GCS 13 and 15, what are those symptoms that we're talking about so you guys are paying attention? So what am I talking about? I said greater than 7 to 10 days, those symptoms persist. What are those symptoms? Headache, nausea, dizziness. Good. Okay, good. Just making sure. I know you guys are tired. If it goes greater than 3 months, that post-concussion syndrome becomes post-concussion disorder. And those are more ICD trackable, your International Classification of Disease trackable codes, right? So I'm not, the timeline on it, just know that for me. So typically you have a mild concussion, you should be better. Like we said, 24 hours brain rest, right? So in 24 hours, if it's your first concussion, all things being equal, you should feel better. But you may have symptoms up to a week, and that's okay. After that, 7 to 10 days to 3 months, we're calling it syndrome. After that, 3 months on, we're calling it disorder. Is that fair? All right. Trying to remember what else I want to say. I will make sure to hit that. There's a question on either syndrome, disorder, and it has to do with timeline. So just while you're looking at it, if you are. What am I talking about? I'm like 4 tests away from you guys, right? Ain't nobody looking at this stuff this weekend. When you guys study this weekend, come on, man. Let's be honest. All right, a moderate TBI, GCS is 9 to 12, right? So if they're having any score, 9 to 12, and you're concerned about them, admit them, image them, right? So take a look for cerebral hematoma, subdural hematoma, epidural hematoma, those type of things. And that's kind of bleeding into spaces that there shouldn't be blood. So after removal of the hematoma, they usually get better. And they may have a week of fluctuating symptoms. That's pretty common. But these folks were not sending them home, right? So like you come in, I'm concerned about the MOI, your GCS is 9 or 10, and I CT you and you have a subdural hematoma. Yes, we found it, right? Sorry, man, go home, take some Tylenol, get some brain rest. No, we need to call somebody. You got blood buildup in a space that shouldn't be there, so you guys got that. That's a call to neurosurgery, and that's an admit. 3 to 8, what do you do? 3 to less than 8, intubate, right? So protect the airway, and I know you guys haven't had emergency medicine, but this is airway, breathing, circulation. Your primary survey, you gotta get them an airway established. These folks got something severe going on. So intubate, admit, image, manage your intracranial pressure, prophylactic antiemetics, and also I'd say anti-nausea meds too, just to help because with that potential shifting of brain tissue, they may get nauseous. ICP goes up. So we'll talk about like, how do you manage ICP? Stroke has a lot of this, so I'm doing this a little bit out of order. For us, well, let me ask a question instead of saying, "Ole, we'll do it next week." How would I manage somebody's intracranial pressure? What do you think? Elevate the head, manage their blood pressure. Hypertonic saline, so 3% NS. What else? Diarrhea? What did you say? Diuretic. Yeah, that makes more sense. Mannitol, so you can use a diuretic, you get some of that fluid off there. And we'll talk more about this. I just don't want to just manage it, right? But that's a lot of times when I have hemorrhagic strokes, subdural, epidural hematomas, those are things that I'm doing. Like, I'm not going to fix your problem. And you don't want me to drill into your head. Like, that's a lot. I would try if we had to. Like if we're on the side of a mountain and you're going down the drain and it's like, I get that little hand crank that's in my sets, kits, and outfits, and it's like, you're gonna die if I don't do this. I would say a prayer to the Almighty and be like, let's do it, man. I would try to find Coker's point and I would drill for oil. Like, that's suboptimal, right? We don't want to do that. However, when you're in my ER and you're bleeding in your brain, like I need to, like I don't just go, oh shit, you're breathing. Like we need to get the neurosurgeon down here. Like what's his blood pressure? Oh, it's 250 over 180. I'm like, well, that's probably not good, right? That's probably making things a whole lot worse. So let's focus on blood pressure management. Let's make sure they're not going to have a seizure. Let's do Keppra 2 grams. Let's do anti-nausea medication. Let's do some Zofran so they're going to start puking on themselves and increase their ICP. Plus or minus 3%. Normal saline, mannitol, all that stuff is all wheelhouse as PAs, okay? Don't want to drill holes in each other. That's great, but that stuff keeps me up at night. All right, cranial nerves injured with your TBIs, and commonly you see your olfactory, optic, ocular, motor, trochlear. Don't memorize these, but these are just based off where they are, okay? Based off their anatomy. We'll talk a little bit about epidural, subdural hematomas. So epidural between the dura and the skull, and then subdural is beneath the dura, right? These are life-threatening. So we're now kind of, the reason they're in the concussion lecture is because these severe concussions can be a result of a epidural or subdural hematoma. So, epidural hematoma, trauma, progressive coma, and then lucid intervals. What does lucid interval mean? People crash their cars into a tree or each other. They get out of the car, and then they go down. Oh man, they lose consciousness, and they get up. What happened? I'm fine, man. Oh, I don't know what's going on. And they fall back down, right? So they're coming to and from. And that's a concern. Usually that's because they're bleeding and clotting, and their blood pressure is going up and down. So you guys can see there, most commonly caused by the trauma to the middle meningeal arteries. This is arterial bleeding. I would like you guys to know that. I would like you guys, if it's not underlined on yours, please do it. Your classic CT findings: convex hyperdensity on the side of the brain tissue in the parietal temporal region. Mortality is 100% if we don't find it, so stakes are up. So if you guys are like, that scares the crap out of me, so most of my people that come in with head trauma, I'm going to CT them. Okay, that's what you have to do to come to grips with it. Like, just be able to articulate it. Why did you order a CT scan for this person with a GCS of 15? Well, sir, ma'am, the mortality of an epidural hematoma, if untreated, is 100%. I don't want to miss it, right? I don't want you to necessarily think that way, but have a good answer. Always have an answer in your back pocket. Okay? We're going to get a CT for these folks if we're concerned about it. What's this going to look like on CT? You guys remember? Yeah, you're on it. So the side, right? So white blood fluid and blood, in this case, is going to show up as white. So that's a problem for you guys? It's not a problem for me. Yeah, it's a problem for them. Exactly. That's a good answer. Eventually this is going to become a problem. I don't really see, their ventricles, they're not really shifting yet, but eventually you'll see a right to left shift to those ventricles. We can herniate left to right so far, and then where do we start herniating after that? Down. We start herniating down into the cerebral tonsils. What happens there? Finger to the throat is death, right? So that's progressive. So if this bleeding and this expansion continues, it will eventually go left to right as a compensatory factor so much. That's going to suck for the patient. And then eventually when it starts going down, that's when patients start to die. So it's quick. It's important that we recognize it quickly. Star this for me, because you guys, I'm going to give you this picture on your exam. I'm either going to give you this picture or the one right here. I'm going to ask you, maybe I'll ask you both. I don't know. We'll see how you feel. I think these are kind of important, no misses. And it's not going to be the picture with an arrow and says, which one is this? I think that's stupid. I'm going to give you a patient that just had an accident that is having lucid intervals, and I'm going to put it all together for you guys. And then I'm going to say, you get a prompt CT because you're the best PA ever, and this is what you get. And I'm going to show you a picture and be like, what's going on with this patient? And you guys would be like, oh, it's tearing in the middle meningeal artery. It's concerning for that moving tongue, right? Anyways. Totally? Well, you will at least by next Tuesday. You'll know that. And we'll dial it in a little bit more. So. All right, subdural hematoma. This is blood in the subdural space, right? We said epidural hematoma was an arterial bleed. What do you think subdural hematoma is? Venous bleeding, okay? Okay, these are still life-threatening potentially, but usually, I don't want to say less. I see these more often, but they're less life-threatening, okay? You can see there, it's a bleeding from the cerebral vasculature, usually from a blow from the front or back of the skull when it hits something, windshield, ground. These are your bridging veins, and you can see this stuff. And this is unfortunately where I see it, is like chronic subdural hematomas in the elderly. From falls that it's healed already or it started to heal. And depending on how fresh it looks on CT or what your neuro exam is, 80, 90-year-old, what do you think neuro is going to do for this? watch it. You guys have one, you fall, God forbid, I won't say it, but you know, I'll put the juju on me. I fall down the stairs and get a subdural, they're probably going to try to drill that out for me, right, and evacuate that blood. But with the comorbidities and how old people do, they'll probably say, are they stable? Yeah, they're stable. They may have had this for weeks or months. Like, I'm not really stoked to throw a drill in their head and try to do anything to them. So. All right, venous blood pressure, venous blood is lower pressure, will clot faster. Clotting continues to increase the size of the mass. Stretching in the meninges can cause headaches, right? So again, worst headache of your life. Patient, you got to consider this. Stupor coma. They got any neuro findings, be concerned about that as well. It can be fatal, of course. We got bleeding where it shouldn't be. And then that classic crescent-shaped hyper-intensity between the brain and skull, which I think we showed right here. Yeah, you guys can see that on the CT. Again, one slice of the CT is kind of trash, but unfortunately that's what I can give you on the exam. And like I said, it'll be part of a presentation, not just a picture. There it is for you. So patient probably didn't do well. Anybody? Yeah, it's post-mortem, they're dead. They're gone. Yeah, they're gone. Yeah, they didn't make it. So definition stuff. Please know the definition of coma. Deep sleep-like state with eyes closed from which the patient cannot be aroused. Cannot be aroused. They're not waking up, right? They're like sleeping, but they don't want to wake up. Versus stupor versus drowsiness, okay? Coma usually is a result of structural damage from the RAS or any of the cerebral hemispheres. Can be suppressed with drugs, toxins, metabolic issues, anoxia, uremia, and liver failure. And right, we can kind of use this to our advantage. How so? Would I want to put somebody in a temporary coma ever?
Yes.
When? With a surgery, right? So if I'm getting my ACL fixed and they give me a bunch of probe, I'm in a sleep-like state where I don't want to be awoke, right? Do people wake up during anesthesia and surgery? Yeah, all the time. You guys see that in phase 2. Like, hey, I think they're waking up. Anesthesia, right? He's over there playing Sudoku, like, yeah, what? No. And then they like wake up and rip their IV out, and everybody's like, ah. But you can also suppress it with illegal drugs, like certain toxins you got to consider with our patient that's in a comatose state, metabolic issues, and these are things that when they come in and they're presenting in a comatose state, you're going to have a pretty good workup on them, right? So full labs, drug tox screen. You're going to check them out from head to toe and see if there's something causing it, and if there is, we're going to try to reverse it, right? All right. The most important brainstem reflexes, pupillary sign, ocular movements, and then respiratory patterns. So pupillary sign, we pretty good with that one? Yeah? What's that entail?
Just
Perla? Are you guys with me? Who's with me?
I couldn't remember the word.
Who wants to just go home? Oh. We're almost there. Like, we're going pretty fast. Yes, so this is why with our trauma patients we shine lights in their eyes, right? We're looking for a consensual pupillary response. Pupils move around reacting to light. Thank you for playing. Ocular movements we'll talk about in a second. You may or may not have seen these before. And then respiratory patterns. Shea and Stokes breathing, what is that? Agonal breathing, right? So that's brainstem kicking in. So like cessation of breathing, gasping, right? And they're like, oh my God, grandma's alive, save her. And you're like, she just met Jesus, like they're shaking hands, right? Kuzma breathing, what is that? Trying to off gas, right? Usually stagnant DKA kiddos is what you see that in, is they're breathing, trying to off gas the CO2. So. All right, oculocephalic and caloric testing. So you guys will get to see this phase 2, or you're trying to, if someone's being pronounced dead, using brainstem activity, you'll look in the eyes clearly. Another one that's commonly done is gag reflex, right? What gag reflex, cranial nerve, what? 11. I heard 10, I heard 11, I heard 9, I heard God bless you. Just look at it, just take a look at it before next test. So you'll consult neuro, and neuro's gonna wanna know, and they've done this to me before, like, hey, this person is brain dead. Like, oh, did you do oculocephalic testing? Did you do a gag reflex? How are, all those things. So, oculocephalic's pretty easy. Doll's eye. We may have talked about this with hints. So head forward, right? You're moving the head side to side. If their brainstem is intact, their eyes should kind of keep fixated. If not, their eyes are going to the side. Their eyes are going with your movement. Right? What's the matter? Show me a better way and I'll do it.
I'm sorry, so we're still on like the gag reflex and none of us know it. So that's what we're talking about. It's not.
Okay. Cold caloric testing is putting a syringe, cold water catheter, and you're squirting it into their ear, okay? And you're looking for nystagmus to the side of the ear that you're squirting the water in. Does that make sense to you guys? Y'all want to try this on each other over the weekend? Could you try it on each other? Yeah, you could. Should you? Probably not. So, sometimes you'll hear cows or cold opposite, warm same. That's a little bit misleading. I've heard that in med school, or some of the physicians are like, oh yeah, cows, that's cows testing. I don't know how that came about. Let me see, it's in here somewhere. I think I wrote it down. Comatose patients, nystagmus is the opposite direction. It may not occur. The acronym COWS has been used to remind generations of medical students of the direction of nystagmus. Cold water opposite, warm water the same. But since nystagmus is often absent in the opposite direction due to the frontal lobe dysfunction in coma, this mnemonic doesn't hold true. So that's why I don't have it up there. Sorry that I told you guys that. You're like, why mention it if it's not there? I want you guys to know cold water in the ear. If you think it's comatose, we're looking for brainstem activity. Eyes goes towards the side. You can see that middle picture. Homegirl has one eye going towards the side of the cold water. What do you think that means? Is she dead? She has a partial response. So something's going on. That's not entirely normal, but she's not dead yet. We can't say she's dead. She still has a positive cold caloric response, okay? This is just your pupillary light reflex. Taking a look at that. I think we talked about it previously. Bottom line with this is labs for a patient that's in a stuporous or comatose state. What do you think you're going to order? Everything. Shotgun, right? Then you say, oh, I'm going to get mad when you guys say that. I'm not. You're going to order anything you can think of, really. And they're going to be like, well, that's insane. Why would you order that? Because before I say they're dead and completely gone, I want to make sure I check out everything. So this may not even be all-encompassing, but glucose, electrolytes, BUN creatinine, Chem7, LFTs, PT, PTT, INR, CBC, ABGs, absolutely CT. I would probably say CT, non-con, with con, CTA, lumbar puncture, make sure they don't have meningitis, because I've seen that in a sleeper state. EEG to check brain activity, right? So you should see some sort of brain activity. These are all things we want to make sure that we do for this person before we walk in there and we're like, ah, you're done. Yeah, you're done. Like,
Time to death.
yeah. Definition of brain death, please start this. Irreversible loss of function in the brain, including the brain stem. So just double line, irreversible. They're not coming back. So can you pronounce somebody dead as a PA?
Yeah.
Yes.
Yeah, you can. In Texas, you can. Check it state by state. In the military system, you can. Do they typically want PAs doing that?
No.
I don't know. It's weird, right? So Texas is strange. Don't ask me. I don't make the laws. But when you get your license in Texas, you have to take a jurisprudence exam. And they're like, who can pronounce people dead in Texas? And it's like NPs, PAs can. 2 nurses can. It's like, hey man, you want to go pronounce them dead? Yeah, they're dead. How about it? Yeah. And then usually where I work, so people die. We probably see, I don't know, say like that. Well, one person a shift dies all the time, but I feel like there's a lot of cardiac arrests that expire. And typically I'm always on shift with a DO or MD, and they would rather have them sign it 10 times out of 10. You think I'm offended? Hell no. I don't want to get into that litigation stuff. Like, I've had a doc pronounce somebody dead that came back, and I was like, bro, I ain't signing that stuff. How did he come back? I'm like, I don't know. It's weird. That scares the living crap out of me. So you're like, which hospital do you work at again? I'm not going to tell you guys. So you might not have the choice, right? They'll bring you to BAMC anyways. All right, must be demonstrated irreversible. Again, can't say it enough, right? At the bottom there, you've heard it. You need to be warm and dead before you can pronounce it dead. Why is that? It should just make sense. Hypothermia, right? So all those meds we're pushing, all the ACLS protocol, ATLS protocol we're doing, like, really doesn't take effect until the body's at temperature. So what type of temperature should I be getting on these folks? A good one. A rectal temp, right? So rectal temp on these folks always. Granted, like, we do get cold weather here. Like, eventually it will turn cold. I promise you that. So there's an opportunity to have a hypothermic patient in cardiac arrest, but they got to be warm and dead before they're dead. Okay. You'll see that if you guys get stationed up in Alaska, like up in Northeast, anywhere, I'd say like north of the Mason-Dixon line, you'll see that stuff. All right, 3 cardinal features of brain death: coma, unresponsiveness, absence brain reflex, we just talked about it, and apnea as well. So no respiratory attempts even with PCO2 at 60 millimeters of mercury. So pitfalls, make sure it's irreversible. Make sure it's irreversible. Okay. So obviously there's a list of them there. Facial trauma, right? A lot of things can kind of look bad, but the human body can take a beating depending on their comorbidities and their status before that. But sedatives, so copious amounts of sedative drugs can masquerade. Opioids, my God, the fentanyl crisis, like fentanyl. You see some of these videos now, some of these patients that are like hopped up on fentanyl. And my son told me it's like fentanyl or something. Have you heard of this or seen this? Yeah. They just look like they're broken in place. No, haven't seen it. They're just walking around the street. I guess it's because I'm from Massachusetts and that's where everybody does all the drugs. That's why all my high school buddies send it to me. Yeah, they look like zombies, man. So let's make sure we Narcan those folks a bunch of times. Comatose patient comes in. One of the first things I'm doing is I'm not even waiting. We're pulling labs, we're getting rainbows. We're, if they need to be ACLS revived, we're doing that. But we're also simultaneously zapping them with some Narcan, trying to see if that does anything. I hate to say it, like a good 50% of the times they respond to that. Okay. Make sure you document it. What do you think you want to put on your documentation? Everything, of course, yeah. But most important, if you're documenting that somebody is deceased, irreversible, time of death, irreversible, 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 demonstrated by the following. I did what? What did you do? Confirmed it. Yeah.
Warm them up.
What did you do?
Does it furlough?
No response to painful stimulation. What did you do? Grab their nail beds, pinch their nipples. I don't care whatever you had to say. Absent pupillary response, oculocephalic, gag, grimace, and apnea, no apneic response. Okay. Make sure you guys do that. All right, where are we at? I think I have, oh yeah, so this cold water, let me see if this is going to show up. So you guys don't do this at home.
Just complain the whole time.
You guys are going to see headaches a bunch. So I don't want you guys to think like, oh, we're going to power through this just to get you out of here for Friday afternoon because it's Miller time. Whatever that means. I've heard it before. But all the cool kids are saying that. You guys are going to see headaches, so this is important. We'll talk primary headaches and then we'll be done. So you guys. What's that?
So it's our test on Monday.
Oh, there we go. Perfect. So you guys, this is good. So this will be a quick, good review for you guys. So international classification of headache disorders. So you guys can see there's primary and secondary headaches. We're going to talk primary, which are your migraine, tension, cluster headache, and then this other category, which primary headache associated with sexual dysfunction falls under. We'll talk about those 4 and we'll be done, okay? But most of your headaches you're going to see are primary headaches. What's the number 1 headache type you're going to see? Don't read the slide. It says number 2. Tension headaches is the number 1, followed by migraine headaches. So if you guys are like, man, this headache stuff is too much for me, like get comfortable with tension headaches and get comfortable with migraine headaches. It's really how to delineate the difference between the two, and that's going to kind of fix a lot of your woes or concerns about headaches. So. All right, we'll talk migraines first. Second most common cause of headaches in the U.S., women greater than men. recurring syndrome, so you usually don't get a migraine once, it's usually happening multiple times. And sometimes you can get these triggers, right? So folks may know what's causing them. You guys talked about some of those triggers? What sort of things trigger migraines?
Light.
Anything? Light, drugs, foods, alcohols, stressful events. Good, you're on it. So it really depends on the person. It's individualized to that specific person. So hormones is another one, right? So estrogen, Ori perfumes, like smells, I guess. Barometric pressure changes, that would suck. And then nitrates in foods, these are kind of all documented ones. So pathogenesis, what's going on with the migraine? So thought to have something to do with trigeminal vascular system, also serotonin, dopamine, and genetics have a play in this. Trigeminal vascular system, why do we think, what does that mean?
Like too much. It's like if there's too much dilation, can it cause a headache?
Yeah. So remember, what follows nerves? Vasculature, arteries and veins, blood. Good answer. So if you have like swelling or something's going on with a nerve, you could have some compression, either blood constriction or dilation, like you said, could be affecting that as well. So how do we know serotonin and dopamine have a play in migraine headaches? You just know? Is that good?
You know the drugs that fix them are serotonin.
That's a great answer, man. Thank you. So the drugs that we treat these with are going to involve serotonin and dopamine, right? So that's how we know it. So, good. I think that's what your test is on Monday, isn't it? Are you guys that smoked? Oh! We got this.
Don't give it.
Primary headaches, we got this. And then inherited or hereditary, like see apples and trees, right? Mom and dad have headaches, mom and dad have migraine headaches, cluster headaches, tension headaches. There's a good chance your patient's going to get them too. Yeah, it's not 100%, but that's why we get that past medical history, family history, okay? Some causes, we kind of already talked about this a little bit, so I don't necessarily memorize the release of vasoactive neuropeptides, CGRP. I don't know if you guys talked about that. You did? Amen. That's awesome. I would just know that, what we talked about, nerve, artery, veins, some of that is going to cause some headaches there. So serotonin says it's unclear, but we use our meds, same for dopamine, and then genetics we talked a little bit about it. This is just showing you the artery and vein that follows that nerve, right? And either causing compression or dilatation of that can result. Any disruptions of that could cause a change or trigger a migraine. Star this one for me. So yeah, unfortunately, like you got patients coming in. I'd like us to know migraine without aura is way more common, 80 to 20%. And then the criteria, right? So at least 5 attacks fulfilling B through D, which is headache attack, last 4 to 72 hours. With at least 2 of the following: unilateral location, pulsatile quantity, moderate to severe intensity, and aggravated by avoiding physical activity, walking, climbing stairs, okay? Also, during the headache, you get nausea, vomiting, or both, or photophobia and phonophobia. What is that?
Light.
Aversion to light noise. So when you walk in the room and the patient's having a migraine, what do they typically look like? Like a vampire, right? So the lights are off, and first thing you do is you turn the light on because it's weird walking into a dark room, and they're like, turn that shit off, right? That's usually not pathognomonic to say like, God, headache, okay? This is a migraine, right? But that's usually an indicator that photophobia and phonophobia, like you come in and you're like, hey, I'm Chris, I'm a PA student. They're like, calm your voice, turn the lights off, and take it down 17 notches. Like, I'm so excited to be here. Simplified diagnostic criteria. I think this one's easier to remember. Pounding. So that pounding pneumotic, pulsatile, onset duration 4 to 72, unilateral, nausea, vomiting, and it's disabling. Really, one of the key things in delineating between a migraine or a tension headache: unilateral versus band-like distribution, right? So it's not always 100%. Some folks can have migraines. They don't, like, not everybody reads the books, right? So like, you're like, man, I feel like I've got pulsatile pain behind both eyes, and I'm nauseous and photophobic. That may be your migraine, I don't know, but by the book, by the way this should present, migraine should be unilateral, tension headaches will have a band-like distribution. That's one of your delineators between the two. You also don't get nauseous and photophobic with tension headaches. So. Chronic migraines, you got to have at least 15 headache days a month with at least 8 days of migraine features for more than 3 months. So we need to know what the takeaway with this is. When your patient comes in and you treat them, you think, first of all, you can't really diagnose a migraine the first time you see them. You can have a high index of suspicion. But remember, they got to meet that criteria. A couple slides back, I know you guys hate when I do this, but going back, it says at least 5 attacks, right? So at least 5 attacks. So you come in and see me, I've never seen you before, you've never been seen for headache, and you're having classic pounding, right? Pounding, pulsatile, rapid onset, unilateral, debilitating, photophobia. Can I call it a migraine? Fortunately, I can't. I can put in my note, highly suspect migraine based off pathophys and clinical presentation, but I need those 5 attacks. Same for this chronic stuff. You need these specific criteria, and this will delineate. We treat chronic migraines a little bit differently. We'll talk about that. I think you guys are going to get tested on that. But there's some newer medications, some newer interventions for chronic type headaches, but if they don't meet that criteria, and you guys try to refer them to neuro for this, they're just going to kick it back. They're just going to kick it back. So be careful what you write. So if it's 10 days they've had it and you're pretty darn sure it's chronic migraines, I'm not telling you to lie, but I would definitely say 15 headache days a month, right? Unless you want to kick back and they'll be like, hey man, they still got 5 more headache days, like not doing anything. Do you think that happens in the military system?
Probably.
All the time. Yes, ma'am.
Do you have them do a lot?
Absolutely, 100%.
Do you have them describe the headache every time too? Like,
I would. Yeah, I would. Headache diaries are great. Patients don't want to do them, but it can give you that data that you can put in there and substantiate it. But. All right, yes, ma'am.
You said that you usually do not diagnose patients on the first presentation to you. But what about like previous history within the same clinic? You know,
Yeah.
Some people don't see the same
Game on.
every single time.
Yeah.
So what about if this patient presented with previous symptoms on different days?
Yep.
You see it in the history.
Migraine headaches. So as it's 5 in these criteria, international classification of headaches. Yep. And you'll see that too. Like sick call, your brothers and sister PAs will see. I'll see patients from his unit. He'll see patients from my unit. And you got to go back and look, right? Or just ask them, like, have you been seen for this before? Like, I keep coming here. And they keep telling me it's a tension headache and give me Tylenol and Motrin. It's not getting better. So then look back, and maybe this is the 5th time they've been here. Boom, migraines. Right? Easy money. Normal exam, so no neurological deficit. They do appear ill, right? I'm not poking fun at them, but they act like vampires. They don't like the light, and they don't like the noise. Actually, that's kind of misleading. Vampires are usually quite spry when it's dark out, right? So they're actually pretty sick. Your migraineurs look like they're not feeling well, okay? So I don't want to give you misconception about like what's the give me a vampire movie. Yeah, like they're not jumping around ready to bite you on the neck. They're usually like pretty sick. Perhaps a bad analogy. All right, we can do this MIDAS, so don't memorize this, but know that it's a tool for you. So the Migraine Disability Assessment Score. In addition to your headache diary that they may have to do for a couple weeks leading up to this to help you make that diagnosis, a MIDAS questionnaire will also be something you guys can drop down in your electronic medical records and ask them some questions to see how bad it's affecting their daily life or ADLs. Okay, treatment, non-pharm treatment, NSAIDs, analgesics for acute, and then we'll talk prophylaxis here. So who gets non-pharm?
Everyone.
Everybody. If she asks you that for pharm, which she probably won't, she's going to ask you drugs, but if I ask you that, everybody gets non-pharm. Dietary modifications, lifestyle modifications, okay? Diet, exercise, regular sleep, avoid caffeine and alcohol, and not everybody's going to get better, okay? But you should see some improvement. NSAIDs, first line, so analgesics and NSAIDs. I think this is great. Like, can I give you, if I think it's a migraine or a tension headache, a gram of Tylenol, 800 Motrin, and just let you sit there and see if it does anything? Sure. The only concern I have with that is orally, you've got nausea, vomiting, so just make sure you're thinking about that, thinking through the process, right? Yes, analgesics are good. You can't be trying to force Tylenol and Motrin down someone's throat when they're actively vomiting. So that's why I say, like, you have to make the determination as a clinician. Do they need an IV? Do they need IM medication? And that's where you have to kind of flex your hammer of knowledge and fracture some pinkies and be like, yeah, this is what I want to do and this is why. Maybe I PO challenge them and they fail. And now I'm like, all right, I tried to give them a gram of Tylenol and 800 Motrin and they puked it up. Now we can proceed and give them an IV. Or you're just like, you know what, I don't want to mess around with this. I'd just rather give them an IV, liter of fluid, 30 of Toradol, 10 of Reglan, 25 of Benadryl. How many people feel better after that? I don't get many complaints. Yeah, y'all feel pretty good. Y'all be passed out, but anyways, just know NSAIDs and analgesics. So Tylenol, NSAIDs. I don't have a favorite one. Just NSAIDs in general. So. Is this what you guys are going over? Huh? Triptans? Alright. Triptans are easy, man. They all end in? Yeah. Be like, give me a question that says, which of the 5 are a triptan? Be like, yeah, I got this one. Nice. Maybe I'll do that for you guys, just as an homage to this. Did you guys talk about ergotamines and dihydroergotamines? Yep. Yeah. I don't think I've ever used those or prescribed them. So ergotamines, non-selective stimulating, 5-HT1 receptor. They do contain caffeine. Why caffeine? What does that mean? Vasoconstrict, right? So yeah, caffeine is usually going to vasoconstrict. Think about caffeine, nicotine, that makes your blood pressure go up. It usually helps delivery system with this medication. But I have never prescribed an ergotamine to a migrainer. I usually go with triptans first line, but they're out there. So dihydroergotamines. So again, you can use these nasally or parenterally. There's just different levels, right? So nasal is a great delivery system. Again, if your patient is puking and you cannot give them something orally, you can consider this. And then you've got IM, IV, or subcutaneous options as well. So just something to consider. Triptans, you'll see these. You guys will prescribe these for your migraine type headaches. I don't think I really want you to memorize any of this. She's going to get you enough on these. So. Of note, you can see at the bottom there, sumatriptan with naproxen. The DOD is like real finicky about that, so they do have combo meds, but for some reason, whoever took that med and paired it with this med, it's really expensive. But if you order them separately, it's like a non-issue. So I've seen them in the system, and they're like, that needs a special formulary request, or you can just order them separately. And I'm like, I'll just do that. It's easier. So. All right, some oral ones. Don't memorize this list unless you have to for Monday, but it's going to do you no good in neurology in a couple weeks. Rizatriptan, sumatriptan. Sumatriptan I tend to go to. Zomig's another one. Sumatriptan I get good results with. What did you guys learn about triptans? When should they take these? When in like proximity to their headache. As soon as they feel it coming on, right? So this is abortive therapy. I don't know if it says that, but typically, like the problem you'll have is your patients will come back and they'll be stuck in a migraine and try to take this stuff to get rid of it, and they'll be frustrated because it may not be doing the job. But where you get a good amount of results is if they have a aura or they feel a migraine coming on and they take this medication and they abort it. That's great. So. That was something that was always interesting. When I keep taking the sumatriptan, but it's not good. Did you take it before you had the headache? No, I waited until I was miserable. And I'm like, I don't think that's the right way to do things. But all right, some other delivery systems, nasally, and again, parenterally, you can do IM, sub-Q, some other effective delivery systems. So, all right. Some other adjuncts, so dopamine receptor antagonists. So these are your Reglan, Compazine works well. You guys talk about those as well? maybe. You're like, I don't know, I'll look at it this weekend. So these are adjunct therapies. They're going to improve gastric motility and improve the absorption, as well as relieving nausea and vomiting. So I talked to you guys about metoclopramide or Reglan. I tend to use that one. I've used Compazine as well. I think they work well. IV, typically when I do that. So, all right. How much more am I going to go? We're going to go 2 more slides and we're going to stop. So, preventative treatment. So, patients with increasing frequency, attacks that are unresponsive or poorly responsive to abortive therapy, 4 or more attacks per month. Their preventative prophylactic treatment usually takes about 2 to 12 weeks before efficacy is seen. You can see 50% success with any one drug, so they may be having to take more than one. Okay. Some preventative treatments for headaches are beta blockers, propranolol, metoprolol, antidepressants, Elavil, amitriptyline, nortriptyline, venlafaxine. Are these familiar to you guys? Okay. I'm like, I hope I'm not telling you anything new. We're gonna leave it at that. Oh wait, one more thing. Topamax is a common one you'll see. I wasn't prescribing it often for migraine prophylaxis when I was first started primary care, and I would kind of frustrate myself. I would do Tylenol, Motrin, Zofran. I would move up to my triptans, and then I'd be like, oh, maybe we should do neuroimaging, make sure they don't have a mass. It was normal. I'd refer them to maybe Neurology, and they'd send them back on Topamax. So got more comfortable with it. Topamax is fine for I think primary care folks to be comfortable with for headaches. You can see with Topamax, the big one is, I don't know if you guys talked about this, cognitive symptoms. Did she talk about Topamax? Yes. Yeah. So these folks come in and they just feel sluggish, or they feel like they're losing their mental, their edge. So I always remember that. Anyways, questions? I'd say under an hour.